I would like to introduce my colleague, Dr. Mohammed Ahmed. He's a medical director of pulmonary and critical care at WKHL, and also the medical director of pulmonary at the Medical Center at Bowling Green. Welcome, Dr. Ahmed, who will be the moderator for session 4.
Thank you, Dr. Dawson, and good morning to everyone. I think it's still morning, right? All right, so far so good. So hopefully everybody is enjoying it. Are you all awake, alert, and oriented times 3? Or they're like electronic medical records, sleeping and oriented times 3. All right, so the good news is after this talk, we'll have a lunch. But the bad news is we'll have a test before that. And you have to pass the test to get the lunch. All right, so enough apart. So we'll move on to taking a deep breath and give some good oxygen to these ailing hearts. All right, so in this next 30 minutes or so, we'll be talking about a couple of topics, which includes pulmonary hypertension and sleep apnea. So first of all, I would like to introduce our speakers and panelists. So my guest speaker is Dr. Sean Smith. He is the Assistant Professor of Medicine and Director of the Pulmonary Hypertension Program at University of Louisville Hospital. He's an excellent speaker and has a great knowledge of the subject. I had the privilege of listening to him before, and I'm sure you guys will enjoy his talk. Dr. Sean Smith, I would like you to come to the stage and have a seat first. So our second speaker will be Dr. Farooq Cheema. As most of you know, that he is the latest addition to our group. And he joined our group about a year ago. He finished his fellowship at the Henry Ford Hospital in Detroit, Michigan. And since he joined our group, he has proved himself a great asset to our group. He's a great physician, an excellent partner to work with. Dr. Cheema. So I will invite my panelists, Dr. David Smith. As you all know, he's a great physician in town. He's our senior partner in the group from Western Kentucky Heart and Lung. He's a board-certified pulmonologist, critical care medicine, and sleep medicine. Dr. Smith. And now I would like to invite our ultimate boss. All right, you know why I'm calling the boss. Like the boss of the boss is the ultimate boss. And the ladies who have those established partners like Dr. Akbar mentioned know why we call them boss. So those 2 to 3 men sometime are 0. You didn't get it. So Dr. Nisar Kazmuddin, she is the senior partner in our group, the medical director at the Sleep Center, the medical director at the Sleep Center of the Medical Center, also associate director at the Western Kentucky Heart and Lung for the Pulmonary and Critical Care Division. Doctors. So let's move on. So I would like to invite Dr. Smith, and his topic is evaluation and management of the pulmonary hypertension.
I'd really like to thank all the folks at Western Kentucky Heart Lung for inviting me to speak about a disease process that I'm very passionate about. I do realize it's right before lunch, and so I'm going to go very slowly and torture all of you. No, it's fairly brief and very informal. So here are my disclosures, some speaking, and as well as some research funding. And I'm going to go over this outline very briefly. We'll talk about the definition of pulmonary hypertension, how we classify the disease. I'll go through a little bit of the pathophysiology and the natural history. We'll talk about signs and symptoms as well as diagnosis. hopefully you'll learn the importance of right heart catheterization for diagnosis, and I'll briefly touch on some treatment options. So what is the background? PAH is a very rare disease. It's classified as orphan. You can see there that it affects 15 to 50 people per million inhabitants, and it affects all ages, all races. It affects both genders. We see a little bit higher prevalence in the female population. And the global burden of pulmonary hypertension is underestimated for multiple reasons. One, it's underdiagnosed, and I'll show you in a subsequent slide that the symptoms are very nondescript, and so it can be mistaken for other disease processes, such as asthma, left heart disease, fibromyalgia, fatigue, etc. And there's increasing risk factors associated with pulmonary hypertension, such as HIV infection, portal hypertension, cirrhosis, and globally schistosomiasis, which we luckily do not have here in Kentucky. So how do we define it? Pulmonary arterial hypertension is defined as a mean pulmonary artery pressure on right heart catheterization of greater than 25 with a wedge pressure, or LVEDP, of less than 15. And it's that increased pressure load on the right ventricle that causes right ventricular dilatation and subsequent death. And you can see on this echo here that the right side is very large and encroaching onto the left heart chambers. How do we classify this disease process? So pulmonary arterial hypertension is classified into 5 different groups. WHO group 1 is PAH, pulmonary arterial hypertension, and that includes the idiopathics, the heritables, drug and toxin. That includes things like cocaine and methamphetamine, and before, I'm sure you've heard of fen-phen. All those have kind of passed through by now, but other things like connective tissue disease, specifically scleroderma, HIV infection, liver disease, chronic hemolytic anemia, this is a little bit older, has moved into group 5. I don't think there's probably any pediatricians here, but persistent pulmonary hypertension of the newborn is also included, as well as a more rare entity called pulmonary capillary hemangiomatosis. Group 2 is the left heart disease, so valvular heart disease, systolic, diastolic heart failure, and then group 3 is underlying lung disease, such as COPD, interstitial lung disease of whatever flavor, altitude, all of those things are in group 3. Group 4 is chronic thromboembolic pulmonary hypertension, so chronic pulmonary emboli causing strain on the right heart and subsequent right heart failure. And then group 5 is kind of a grab bag of other diseases, hematologic disorders, systemic conditions, including sarcoidosis. Why is this important? It's important because patients who have PAH in WHO group 1, those are the patients who are candidates for selective pulmonary artery vasodilator therapy, and so it's very important to diagnose patients who are in this group. What's the epidemiology of patients in that WHO group 1? Well, we know that up to 12% of patients who have connective tissue disease can develop PAH. Up to 30% of patients with congenital heart disease, 5 to 6% in portopulmonary hypertension can develop portopulmonary hypertension, and HIV is associated with up to 5% risk of developing PAH. So it's important to know these groups because if one of these patients who have an associated condition is short of breath or has abnormal echo, they do have risk factor for developing PAH. So how does this disease progress? And so in the top pane, you'll see a normal RV and LV and a widely patent pulmonary artery. And in the normal setting, the pulmonary vasculature and the pulmonary vascular resistance is very low, and the right heart's not under strain. But as you move down in the slide here, you'll see that the vessel lumen becomes stiff and is obliterated by intimal fibrosis, and you can have plexiform lesions, and that causes an increased resistance against the right ventricle, which initially may hypertrophy, but subsequently dilates, resulting in a decreased cardiac output and eventual death. So how does this disease progress hemodynamically? So when we initially see a patient who's in the pre-symptomatic or compensated phase, they may have an elevated pulmonary artery pressure, but their cardiac output, their right heart is maintaining against that pressure. But as pressure increases, you will see that the right heart fails, right atrial pressure will increase, and the patient will become symptomatic and then decline. I tell folks that the name of the game in pulmonary hypertension is not necessarily their pulmonary artery pressure. Yes, that's what initiates and drives everything with the disease process initially, but we really care about what the right ventricular function is in response to the elevated pressure. Here's a couple pictures of echoes. I'm a pulmonologist, not a cardiologist. All the cardiologists can kind of close their eyes when I'm pointing this out, but here's a very large right ventricle encroaching onto a left ventricle, and here you can see a very large RA and RV encroaching onto the left ventricular the left-sided chambers. Also another cartoon, you all see this magical number RVSP, right ventricular systolic pressure, appear on the echo report, and this is just kind of an explanation of how we get that number. The cardiologist looks at the regurgitant envelope from the tricuspid valve and uses that in a formula to calculate what the estimated right ventricular systolic pressure is, and that's important to know because it should approximate the pulmonary artery systolic pressure and gives us a clue if pressures are elevated in the lung. That being said, cardiac echo is not accurate in estimating what pulmonary artery pressures are. You can have over and underestimation of approximately 50%. So in the right patient setting, with the right symptoms, even with the normal echo, you should push forward and ask for right heart catheterization to make sure that there's not underlying pulmonary hypertension. What are some risks in patients who have been diagnosed with PAH? Do they have right ventricular failure? Yes, they're at higher risk. Is their disease progressing gradual versus rapid? What's their functional class? Several other people have talked about functional class, and I'll have a slide coming up to go over that more, but functional class mirrors right ventricular function, so a lower functional class is preferred. What's their 6-minute walk or hall walk distance? We have patients walk a given distance in a hall for 6 minutes, and if they walk longer distance, that's a better prognostic sign. BNP, just like in left heart failure, right heart failure patients can generate BNP, and if it's very elevated, that's higher risk, and if we treat them and that number comes down, we know that patients respond better. Also, on echo, things that we may see that confer increased risk are pericardial effusion, significant RV dysfunction, minimal RV dysfunction being considered lower risk, and then hemodynamics. Like I mentioned before, the name of the game in pulmonary hypertension is not necessarily mean PA pressure, but how the right ventricle is responding to that increased pressure. And the two numbers that kind of reflect RV function is what is their mean right atrial pressure and their cardiac index. A higher mean right atrial pressure and lower cardiac index being more ominous. So patients with PAH, what's the survival by etiology? You'll see here that the congenital patients do better, kind of the portopulmonaries in the middle, and the worst patients are HIV and collagen vascular disease, specifically patients who have scleroderma. Survival is also important. People always ask, how long am I going to live when they get the diagnosis? Early referral and screening is very important for this disease. Without any treatment, we typically quote 3 years survival. With that being said, because the disease is kind of vague, it's difficult to diagnose, people are referred late, sometimes they don't get their right heart cath or referral to a PH center for up to 2 years after symptoms have developed. So we frequently get very late referrals in people who are end stage and difficult to salvage. So what are some symptoms of PAH? Folks can be dizzy, they can be short of breath, they can have some angina, rapid heartbeat palpitations, they're tired, they're fatigued, their belly is swollen, they have ascites, they have lower extremity edema. you can see why all of these symptoms, they're very vague and can be diagnosed with other disease processes. I've had multiple patients be diagnosed with seizure disorder or generalized anxiety disorder, all kinds of arrhythmia issues, people that are diagnosed with cirrhosis when actually they just have right heart failure and chronic volume overload causing ascites. Here again, New York Heart Functional Class. We determine what the functional class is at diagnosis, and then with each subsequent visit. Functional class is important because it should mirror what right ventricular function is doing, and it's also important because it is associated with what therapies we should have a patient on. So a lower functional class would be associated more with an oral therapy or combination thereof, and a functional class 3 or 4 patient would be a candidate for a more advanced vasodilator regimen, which I'll discuss. So how do I diagnose this disease? Everybody gets the obligatory history and physical, and we ask about family history. Everyone is screened for lupus because lupus is associated with PAH. Chest x-ray is typically obtained, but all these findings are really not specific for pulmonary hypertension. We do get echo, but again, as I mentioned, an echo may be inaccurate up to 50% of the time for estimating pulmonary artery pressures. Things that make you really feel like the echo is, and the PA pressures are truly elevated, is as an enlarged RV or RA. An ECG, cardiac catheterization. There's a later slide on this, but it allows us to directly measure the pressures, to look and see if left heart filling pressures are elevated. It also allows us to do vasoreactivity testing and establish severity of the disease based on the pulmonary pressure, the cardiac index, and the mean right atrial pressure. We do a pulmonary function test, and with diffusion capacity, that really lets you exclude those patients who have obstructive or restrictive lung disease like COPD or interstitial process. And then one of the most important is the ventilation perfusion scan. That lets us rule out chronic thromboembolic pulmonary hypertension, and the reason we care about that disease process the most is that it's potentially curable with a surgery called pulmonary thromboendarterectomy. And so here's our diagnostic testing algorithm. All of those I've kind of already gone through. I think not included in the previous slide was overnight oximetry or polysomnogram to assess for sleep disorder breathing. OSA and obesity hypoventilation are associated with pulmonary hypertension. However, they'll only generate usually mildly elevated pressures, and if treated, pressures can normalize. We also do serologic analysis on all these folks, HIV, ANA, etc. I do screen for scleroderma if they have physical findings suggestive of scleroderma, and then the right heart catheterization to include things like vasodilator testing, exercise testing if needed, volume loading if you're expecting diastolic dysfunction, and then in the appropriate patient, a left heart cath with LVEDP. So the right heart cath really lets us confirm the diagnosis and is the gold standard. It lets us assess for congenital heart disease by looking for abnormalities in oxygen saturation and shunt step-ups, excluding left heart disease, and by that statement I'm saying elevated wedge pressure or LVEDP. We get to do the vasodilator test to see if the person is acutely vasoresponsive, which would make them candidates for calcium channel blocker therapy, and assess other hemodynamic parameters. Why is it important again to do the right heart cath? This is a little bit in semantics, but if we think about pulmonary hypertension, that includes two processes really: pulmonary venous hypertension, which is high pressure generated from the left side of the heart, so valvular heart disease or systolic or diastolic dysfunction, and it lets you subtract out the patients who really have PAH, so that the pressure, the elevated pressure, is being generated by the pulmonary artery. And in that setting, you'll see a high PVR, a high transpulmonary gradient with normal left-sided filling pressures. So what are some disease pathways? These are the 3 primary disease pathways in PAH. There are several others, but these are the most important because these are the ones we have therapies to address. I won't go through each individual step in the pathway, but endothelin is involved in PAH, endothelin being a very potent vasoconstrictor, and we use medications to block that effect. The nitric oxide pathway, patients are deplete in nitric oxide, being a vasodilator, so we block with PDE5, which increases NO generation and vasodilatation. Patients with PAH are also deplete in prostacyclin, and so we replete prostacyclin, which is vasodilatory and antiproliferative, as well as some antiplatelet effects. And I'm not sure if most of you guys have even heard of these medications, but we'll go through them. Endothelin blockers are bosentan, ambrisentan, and maxitintan. We use phosphodiesterase inhibitors. I'm sure you've heard of these. Sildenafil and tadalafil. They have special trade names in the pulmonary hypertension world, different from their erectile dysfunction world, but all the old 80-year-old ladies like to tell everyone they're on Viagra. The prostacyclins, we have epoprostenol, treprostinil, and iloprost. Those are either infused or inhaled therapies, and now we also have an oral therapy in that class. And then calcium channel blockers. So calcium channel blocker therapy. Everyone is always confused. When do we use calcium channel blocker therapy with PAH? Why are we doing vasodilator testing? Is vasodilator testing is positive or negative? What does that really mean? So in the cath lab, if someone has elevated pulmonary artery pressure with the normal wedge pressure, then we will give them a vasodilator to see if they are acutely vasoresponsive, meaning that their pulmonary artery pressure will drop. And the new definition is that it will drop by 10 millimeters mercury to less than 40 with the maintained or increased cardiac output. If folks meet that definition, then they're candidates to treat with calcium channel blockers. Only 13% of patients with idiopathic pulmonary hypertension really respond to this test. And out of that 13%, in previous studies, only 6.8% had a favorable response at a year. So it's important to identify these patients because there's a very small subset of folks who are calcium channel blocker responsive, and they'll stay responsive for decades even. And it's much cheaper to be on a calcium channel blocker than a combination of the other therapies that I showed you before. I will make a note here that the calcium channel blocker therapy that we use is not your standard low-dose calcium channel blockers like for blood pressure, systemic blood pressure. So, for instance, if I just diagnosed a 30-year-old with IPAH and she was vasoreactive and she is now on 30 milligrams daily of amlodipine. So it's higher doses, it's difficult to tolerate. People will have a lot of edema, they'll have a lot of GERD and flushing, etc. So it's very hard to maintain calcium channel blocker therapy. There's a new therapy for patients who have chronic thromboembolic pulmonary hypertension called riociguat, and it's a soluble guanylate cyclase stimulator that does a couple things. It enhances sensitivity of SGC to nitric oxide and also stimulates SCG to synthesize cGMP even in the absence of nitric oxide, and this has been approved not only for group 1 PAH but also group 4 chronic thromboembolic disease, and it's an oral therapy. I think I'll skip that slide. Infused prostacyclins. I've had medical students, nurses, etc. ask me before, you started this fancy infusion on this patient in the hospital, when are you going to stop it? And the answer is never. They go home on this therapy, they maintain the pumps, and the infusion is continuous. So treprostinil can be infused by a variety of pumps, and those can be either subcutaneous or intravenous. Epoprostenol, kind of the old standby, has to be is intravenous only, but those are kind of the different options that those medications can be infused. We can also provide prostacyclins through an inhaled route, and there are two different options, inhaled iloprost or inhaled treprostinil. Everybody thinks you're going to give them an albuterol inhaler when you tell them that you're going to put them on an inhaler for their pulmonary hypertension, but this is a little bit different. It's kind of a bulky inhaler that they use 4 times a day. This inhaler with iloprost is dosed up to 6 to 9 times daily. So how do we treat patients with PAH with all these drugs that I mentioned to you? Well, we used to anticoagulate them all. That's fallen out of favor. There's not really a lot of evidence for anticoagulation chronically unless the person has an indication for chronic anticoagulation like atrial fibrillation or PE, et cetera, or chronic clot. We give them diuretics, we give them oxygen and digoxin. We do the vasodilator testing during their heart cath, and if positive, place them on calcium channel blocker therapy and monitor for their response. If they're negative calcium channel blocker, they're at low risk, so they're functional class 2 with low risk, then we will typically put them on some combination of oral therapy and then advance as needed to add on other therapies such as prostacyclins. If they're at a higher risk or more advanced functional class, then add in prostacyclins and orals simultaneously. Knowing that in the end, if both of those don't work or the disease progresses, that the patient will be a candidate for an atrial septostomy potentially or a lung transplant. There's also interesting that on this slide there's lots of arrows connecting everything down here, so that means that there's no consensus about what we really do. I don't think there's a good answer of what to add first. So what are some treatment goals? We want to improve the quality of life in the patients with pulmonary hypertension. We want to get their functional class down, hopefully to 1 if possible. We want to get their 6-minute walk distance up. We want their right heart to recover and their mean right atrial pressure to drop and their index to improve and alleviate their symptoms. With these therapies, has survival improved? And you'll see here really that survival has improved. That being said, there were several registries, which I spared to show you, that show that we're still not following treatment guidelines. And when I say we, I mean pulmonary hypertension centers as a whole. So even partially following the guidelines, we've had improvement in patient outcomes. And so there are now kind of pushes to more strictly follow guidelines that have been set to treat these folks. So I would encourage early referral and screening of high-risk patients, like patients who have scleroderma or HIV potentially. And with that, I will end. And any questions, or save questions to the end, I guess.
Thank you, Dr. Smith, for a wonderful talk. So our second speaker is Dr. Chima, and he will talk about the obstructive sleep apnea in relation to the cardiovascular disease. Dr. Chima.
Thank you. Thank you. So I'm going to be talking about sleep apnea in patients with cardiovascular disease. I have no disclosures. I do have a disclaimer. I'm going to try to beat Dr. Slaughter's speed record because I'm not going to keep you from my lunch, and more importantly, I'm not going to keep myself from my lunch. So obstructive sleep apnea is a type of sleep-related breathing disorder that basically results in either partial or complete cessation of airflow despite an ongoing effort to breathe. It's usually due to a combination of anatomical factors and a decrease in upper airway muscle tone during sleep. How we define sleep apnea not only affects how we measure its prevalence, but also how we identify patients who are at a higher risk of morbidity and mortality from this disease. So apnea is defined as a cessation of breathing with respiratory effort lasting for more than 10 seconds. A hypopnea is an airflow decrease of 50% or more, or decreased airflow with a desaturation of 4% or more. And the total number of apneas and hypopneas per hour are defined, is called the apnea-hypopnea index. An AHI of 5 to 15 is mild sleep apnea, 15 to 30 is moderate, more than 30 is severe. This is data from the Wisconsin sleep cohort. They looked at about 1,500 people in this state, employees basically, who had a diverse range of social and ethnic and socioeconomic backgrounds. And using a cutoff of an AHI of 5, approximately 24% of middle-aged males and 9% of middle-aged women had sleep apnea. Using a cutoff of an AHI of 15, the number got down to about 9% of middle-aged males and 4% of middle-aged females. This translates to about 12 to 18 million people in the United States who have obstructive sleep apnea, and generally it is underdiagnosed as a disorder. The incidence appears to be increasing as the population is not only aging, but the incidence of morbid obesity is also increasing in the population. This is just a slide that reviews some of the pathophysiological mechanisms on how sleep apnea can cause cardiovascular disorders or contribute to cardiovascular disorders. Repetitive hypoxemia and reoxygenation can cause oxidative stress. Changes in intrathoracic pressure can cause decrease and increase changes in preload of the left atrium. Repeated arousals can cause sympathetic activation and also lead to metabolic derangements, all of which contribute to systemic and pulmonary hypertension, renal disease, risk of stroke, coronary artery disease, heart failure, and sudden cardiac death. This is data from the Wisconsin sleep cohort, and the interesting thing is that when you look at patients who have cardiovascular diseases and other diseases such as diabetes, hyperlipidemia, hypertension, ischemic heart disease, particularly pulmonary hypertension, congestive heart failure, they actually have an increased risk of having obstructive sleep apnea. So cardiac patients have a higher risk than the general population. This is particularly true when you have patients with more severe disease. This is a series of patients from a hypertension clinic in Argentina. And when you look at people with resistant hypertension, which for the purpose of this paper was defined as a blood pressure of greater than 140 by 90 millimeters of mercury, despite being on 3 different medications to control blood pressure, the incidence of severe sleep apnea was approximately 75% or greater. This slide actually shows the opposite effect, which is basically patients who had resistant hypertension, about 85% also had severe sleep apnea in this cohort. If you look at morbidity and mortality data from the Wisconsin's sleep cohort, patients with sleep apnea had a higher risk of cardiovascular mortality and morbidity, including all-cause mortality and stroke and cardiovascular mortality. This is true in the community as well. This is a study from SLEEP in which they looked at basically all the residents of a community in Australia. It was a community of about 380 people. Everybody had sleep studies, and they followed mortality based on whether patients had sleep apnea using a cutoff of an AHI of 15. And the blue-green line here basically is patients with an AHI of 15 or more, and over 15 years or so, they had a greater mortality. This is, again, also true for cardiovascular mortality and morbidity, and this is a study from Europe which looked at approximately 1,500 middle-aged men, and the solid line you see is people who had severe obstructive sleep apnea with an AHI of greater than 30. And the other lines are mild obstructive sleep apnea, and when you actually treated these patients, their mortality risk improved with treatment. It's really hard to estimate the socioeconomic cost of obstructive sleep apnea because not only do you have the cost of the disease itself, but you also have the knock-on effect of how it contributes to other disorders and other socioeconomic costs such as contribution to motor vehicle accidents, lost work days, et cetera, et cetera. But this is a study from Harvard where they basically kind of looked at all of these costs. It was a study done from McKinsey & Co., never published, but is still available on the Harvard website. And basically, the annual economic cost of obstructive sleep apnea is estimated to be about $115 billion, plus minus $50 billion, which is actually higher than the cost of strokes and heart failure. So it's a disease which can have a lot of economic impact. So now we've talked about the incidence and some of the mortality and morbidity. Now we'll just briefly talk about how treating obstructive sleep apnea can, in some ways, improve outcomes. This is a very busy slide. It's a meta-analysis of all the studies done that have looked at, or all the qualifying studies done that have looked at the effect of treating sleep apnea on hypertension. And as you can see, there's a pretty wide range of results that you see in this slide. But overall, if you look at the pooled data, you see an approximately 3 to 5 millimeter decrease in both the systolic and diastolic blood pressure when you treat patients who have obstructive sleep apnea with CPAP. And when you further analyze this data, the incremental benefit you get is more in people who have more severe obstructive sleep apnea. So if your AHI, for every 10 increase in the AHI, if you treat them with CPAP for sleep apnea, you have an additional 1 millimeter decrease in the blood pressure. There's not a lot of studies that have been done to look at the effect of treatment of obstructive sleep apnea in patients with cardiovascular disease. This is a small case series in which they basically randomized people to receive CPAP and not in patients who had obstructive sleep apnea and coronary artery disease, and they saw an improvement in their primary outcome, which was actually a pooled outcome, which included time to rehospitalization, time to revascularization, mortality. A similar study from Europe kind of looked at more specific endpoints. And when you took the composite endpoint, which include death, cerebrovascular mortality, and MI, there was a significant improvement in treatment with CPAP for obstructive sleep apnea, but this was mostly weighted because these patients had a lower incidence of stroke and not necessarily improved or decreased rate of myocardial infarction or improved mortality. There is an ongoing trial in Sweden which actually is designed to try to address some of these shortcomings, and they've recruited about 400 patients. The trial is done. They're just working on the analysis part. Generally speaking, patients with obstructive sleep apnea have a higher incidence of arrhythmias, and the higher your AHI, the more likely you are to have an arrhythmia. And as you can see, in patients with an AHI of greater than 50, only 13% have sinus rhythm continuously during polysomnographic evaluation. And there's a higher incidence of both ventricular and supraventricular arrhythmias. This is a meta-analysis that was presented, I think, at the American College of Cardiology conference this last year. And it basically looks at pooled data from different trials that have looked at treating patients with atrial fibrillation with sleep apnea and other therapies, and they found that there's a generally decreased risk of recurrence of atrial fibrillation in patients with sleep apnea once they are treated with CPAP. This is data from the CANPAP trial, which is basically looked at treatment of sleep apnea, but actually this is both obstructive and central in patients with congestive heart failure. And even though these patients had a significant improvement in both the number of hypopneas, in their oxygen saturations, even the rejection fraction, this did not necessarily translate into a significant improvement in mortality. A post-hoc analysis actually stated that if you can suppress their central apneas with CPAP, which is the top line, the top gray line there, they had a slightly improved mortality, but this was a very small number of patients. And the theory was that a lot of patients with congestive heart failure have central sleep apneas, and they did the SERVE-HF trial, which looked at adaptive servoventilation, which compensates for that, to see if this would actually improve mortality. And what they found was that there was no difference in the primary endpoint, but patients with heart failure who were treated with adaptive servoventilation actually had a 2.5% per year incremental increase in mortality, which led to the recall of the ResMed ASV device. Just briefly looking at the cost effectiveness of treatment of sleep apnea, as you can see, it is cost effective when we compare to different interventions such as, say, breast cancer screening and hypertension control. And what you don't necessarily see here is the fact that it actually does have a knock-on benefit both with other comorbidities and also socioeconomic benefits. A brief word about sleep apnea and pulmonary hypertension. Dr. Smith kind of mentioned it. Approximately 20% of patients with pulmonary hypertension will have some degree of sleep apnea, but in the absence of underlying cardiac and heart and lung disease and other underlying diseases, you're unlikely to have significant pulmonary hypertension for sleep apnea alone. And when you treat these patients with CPAP, you see an approximately 5% decline, a 5 millimeter decline in the pulmonary artery pressure. So in conclusion, obstructive sleep apnea and cardiovascular disorders are both extremely common. Treating sleep apnea may have a knock-on effect in treating some of your cardiovascular disorders. And screening for obstructive sleep apnea is reasonable in patients with cardiovascular diseases. So.
Thank you, Dr. Chima. Excellent job. So we'll be open to any questions or comments at this time?
Use of long-term monitoring in patients with obstructive. What do you think
patient population, it's not a bad idea. But generally, symptomatic AFibs, which are going to treat anyway, so screening for symptomatic AFib is probably sufficient.
Can you repeat that, Jeffrey?
The question was, should we do long-term cardiac monitoring in patients with obstructive sleep apnea to screen for atrial fibrillation? I think that's not a bad idea, but in general, symptomatic atrial fibrillation is what's going to be treated, so most of those patients will come to attention anyway, but screening them for symptoms of atrial fibrillation is certainly a good idea.
Thank you. Any other questions?
Partial airway obstruction and sleep apnea. And I would say anecdotally that also seems to be associated with obesity. So is there a role for weight reduction? And does it actually improve the outcomes? And if so, as was alluded to by Dr. Lindeman, since we're in the land of milk and honey for obesity, diabetes, and cardiovascular disease, assuming you're overweight and over the age of 50, is there a role for screening such that they should be put in mandatory weight reduction programs?
Yeah, I think that the people that have sleep apnea that do lose weight, that you improve the degree of the severity of the sleep apnea, but it almost never resolves. And I think you have to be, honest with patients about that. You certainly want to encourage them to lose weight, but they probably will always need treatment for the sleep apnea because that's just one of the problems causing sleep apnea. I have a question about Dr. Smith. If he would just comment on the off-label use of some of these specific therapies in treating pulmonary hypertension due to left heart disease. I think that's something that's been a problem in the community.
Yeah, we really don't have evidence to add these therapies for pulmonary hypertension in general unless it's specifically PAH. There's problems coming into play if therapies are added and you don't have the correct diagnosis. One, you're spending lots of money. There are side effect issues. And also we're having patients who are frequently treated based on echo results and not having a right heart cath. It knocks patients out of having the opportunity to be involved in things like clinical trials and receive benefits from studies. So I would really encourage treating the true patient with PAH who has the correct hemodynamic definition, and then all of those therapies be applied, but not in general to a patient who just randomly has pulmonary hypertension noted on their echo.
Dr. Smith, I have a question about CTEP. How common is that condition? How common do you see that? How do we treat it?
So chronic thromboembolic pulmonary hypertension, we really don't know the true prevalence, but it's thought to be even around maybe 1.52% of all patients who have PEs. The things that increase your risk of developing chronic thromboembolic pulmonary hypertension is recurrent clot, I believe B blood type, coagulopathies, having a very large pulmonary embolism with high clot burden increases your risk of developing chronic pulmonary hypertension. Things that may make you think that a clot is more chronic and that it's CTEPH, chronic thromboembolism, and not acute pulmonary embolism, is if you see PA systolic pressures of greater than 50 on a screening echo, then typically that means your right ventricle is conditioned to the high pressure and it is probably a chronic clot. The way that that's treated is pulmonary thromboendarterectomy. So that's an open chest on pump hypothermia procedure, and the surgeon goes in, finds a dissection plane, and essentially dissects all the way down as far as you can get and pulls out the chronic thrombus, which is more like an organized fibrin clot.
You mentioned the new medicine which was recently approved also works in that CTEP.
Yes, so riociguat has been approved for chronic thromboembolism. It's a vasodilator, not an anticoagulant. And therapy in patients with chronic clot is reserved for people who either aren't operable for another reason, or their thrombus is too distal for surgical removal. And those patients we would treat with riociguat. But it's highly encouraged if you have a patient who has chronic thromboembolic pulmonary hypertension that they're referred to a center to make sure that they're not a candidate for surgery because it is potentially curable.